You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for July 17th, 2020. This week, COVID, the XL trial, atrial fibrillation, and pacemakers. First, a brief COVID update, and the short story is simple. America is in a hot mess. Well, not only pandemic-wise, but here I'll just stick with the medical issues. Testing is much more available, but multiple cities and states are seeing increases in COVID. 70,000 new cases in one day this week, a record. As expected, hospitalizations are increasing, and the early data looks like deaths are tracking up as well. The U.S. now has 3.6 million cases of COVID, and I saw this week that in Arizona, 1 in 4 people tested are positive. 1 in 4. The U.S. deaths 2 weeks ago were 135,000, and this week they're 141,000. That rate of rise of only 1.04x is flat, but the flat line belies the focal nature of this pandemic. Florida, Arizona, California, and Texas all show clear signals of increasing rates of hospitalizations and deaths. Another problem we have is inconsistent reporting. We don't seem to have a central repository of data. Internationally, Brazil, Mexico, India continue to report increasing cases and deaths. I read this week that South Africa saw such a surge in cases that the government banned the sale of alcohol. If that happened here, I'm pretty sure the apocalypse would be certain. I want to start by talking about schools. That's a big question now in the United States, COVID-wise. Should schools be open or stay virtual? I mention the school issue because it parallels medical decision-making. Namely, it gets to the risk of trade-offs, the risk of the virus versus the risk of avoiding the virus, just like in medicine, the risk of the disease versus the risk of the treatment. So on the one hand, keeping schools virtual will surely reduce community transmission. That's a good thing. But not having in-person schools surely harms the children's education, their socialization, and of course, parents will struggle. Now, just as it was with the shutdown, viral avoidance measures harm the disadvantaged lower-income people more than it does the rich. White-collar workers are much more able to keep their children up to speed in a virtual classroom. The school question is important because it forces people to think about the concept of safety. How safe does safe have to be? For instance, the American Academy of Pediatrics have advocated for restarting schools because the risk of keeping kids at home is higher than the risk of viral infection. To me, this is a remarkable statement because infectious disease features so prominently in pediatrics. The coronavirus is dastardly. It spreads like crazy, and the vast majority of people do fine with the infection, upwards of 99%. But enough people get super sick or even die that it induces terrible fear. Then fear can cause people to make dubious decisions, like ignoring chest pain or stroke symptoms, or not coming in for a pacemaker check, or delaying treatment of dying patients on the off chance that they may have COVID. Daycare, schools, outpatient clinics, hospitals, even grocery stores are never going to be 100% safe from viral infections. The phrase, keeping people safe, should be reworded to keeping things as safe as possible. Off-target morbidity and mortality from this virus are beginning to worry me as much as the virus itself. Now, last week I mentioned the news of vaccine trials. This week, New England Journal published a phase 1 study of messenger RNA vaccine in 45 healthy adults, and it induced an immune response in all participants, and there were no trial-limiting safety concerns. More encouraging, however, is this lead sentence from a New York Times column this week. Quote, "Of the 150 plus coronavirus vaccines in development." My friends, I am so happy that there are 150 vaccines in development. Really, this is a great thing. I also read this morning that Oxford researchers are going to begin challenge trials. These are trials in which people who have had vaccines are tested by being exposed to the virus. If ever capitalism and free market incentives need to shine, this is it with this coronavirus. The next topic today is XL trial. This week, the New England Journal of Medicine published multiple letters to the editor on a 5-year report of the XL trial. And the authors replied, including a table of new data, and this table is significant. Recall that the XL trial was the largest RCT comparing drug-eluting stents versus coronary bypass surgery in patients with left main disease. The XL authors have published the 5-year results in November of 2019. They published the 3-year results in 2016. About 950 patients in each group. The composite efficacy endpoint was death, stroke, or MI. And that sounds simple, right? Not so much. Death, of course, is easy to count, so is stroke, but the problem came in MI. In XL, the authors chose to use the SKY definition of MI. This definition uses biomarkers and is procedural agnostic. Now that is a problem because heart surgery causes a greater release of cardiac enzymes than does PCI. What happened then in XL is that CABG had higher rates of MI early and then fewer later. In the end, in the trial, there was no difference in MI, and that drove non-inferiority of the composite outcome in the 3-year results of XL. This then led to guidelines codifying PCI and stents for left main as similar to heart surgery. And now, no person ever would choose bypass surgery if their doctor told them the two options were similar. But scrutiny of the actual data complicates this simplistic take on XL. For 5 reasons, and I'll try and be brief. In the 5-year results, the outcome of death favored CABG. At 5 years, there was a 38% chance of being dead if you had PCI. It was 13% versus 9%. That was a whopping 4% higher risk in absolute terms. Now, the authors say the higher death rate could be due to chance. When they looked at causes of death, death from cardiovascular reasons was not different. Of course, the deciding of causes of death is tricky without an autopsy. The second issue was the choice to use a biomarker-heavy definition of MI, which biases in favor of PCI and against CABG. Third, in the 5-year report, the authors conclude that the rate of the composite outcomes, which was 22% for PCI, 19.2% for CABG, were statistically not different. Indeed, the confidence interval went from 0.9 to 6.5. However, recall that XL was designed as a non-inferiority trial. The non-inferiority margin was set out at 3 years was 4.2% risk difference, meaning PCI could be 4.2% worse and still be called non-inferior. Thus, had the 5-year data been analyzed as the 3-year data were analyzed, the upper bound of 6.5 would have exceeded the non-inferiority, and PCI would not have met non-inferiority versus CABG. Finally, and this is a biggie, after the 5-year data was published, the BBC acquired raw data from the trial. This included the rate of MI as defined by the universal definition of MI. The universal definition is one in which CABG is allowed higher enzyme thresholds, and clinical data is required to confirm an MI, things like an ECG or an echo. This showed that at 3 years, the rate of MI was 80+% higher in the PCI arm. And worse, this particular outcome was a secondary endpoint that was set out in the trial protocol. But there was no mention of this key secondary outcome when the 3 or 5-year results were published. These problems led to multiple surgical societies pulling their supportive guidelines and a call for an independent review of XL. The letter writers to the New England Journal of Medicine addressed these issues. The big newsworthy item came when the author's reply included a table with the results of MI as defined by the universal definition. Again, this was a pre-specified secondary outcome. Here there were 89 MI events, 9.6% in the PCI arm versus 43, 4.7% in the cabbage arm. The authors gave us the risk difference of 5%, but the relative risk was approximately 2, meaning if you had PCI, you were twofold more likely to have had an MI as defined by the universal definition. I really worry about this turn of events. The data on higher rates of MI by the universal definition that were published in this letter were very similar to the data leaked to the BBC. This means the data were there. The secondary endpoint of MI by universal definition was specified in the trial protocol. Universal definition clearly says that if troponins are not available, you use CK-MB. I asked then, why wasn't this data published in the 3 or 5 year manuscript? If it were, don't you think it would have affected the conversation about the trial results? Specifically, would we have looked more at the higher rates of death in the PCI arm of both the 3 and 5 year follow-ups if MI rates were double? I mean, non-fatal MIs are not nothing. Recall that the lower rates of non-fatal MI drives the benefit of statins for primary prevention. It's considered a big outcome in those trials. As an exploratory analysis, why is it not appropriate to run a comparison of the composite endpoint with universal definition of MI? This would clearly favor coronary bypass surgery. And again, where were the editors and peer reviewers of the New England Journal? Should it not be normal to look at what the scientists said they were going to report in the experiment and then see if they reported these outcomes? Like many stories I cover in this podcast, I like to find those that inform a specific problem, here the treatment of patients with left main coronary disease, but also I like to find stories that inform the translation of evidence to the bedside. Third topic is atrial fibrillation. Last week, Jason Andrade and Canadian colleagues published a sub-analysis of their CIRCA-DOSE trial. This trial gets us thinking about the definitions of AFib and also the huge knowledge gaps we have in AF ablation. Recall that CIRCA-DOSE, published in Circulation in November of 2019, was a 3-armed AF ablation RCT done in multiple Canadian centers. The 3 arms were contact force-guided point-to-point RF, radiofrequency ablation, versus 4-minute cryoballoon versus 2-minute cryoballoon ablation. About 350 patients. The primary endpoint was time to first AF or asymptomatic AF, and importantly, all patients got an implantable loop recorder, ILR. The main finding was that there was no difference in 1-year efficacy in freedom from AFib, which was only 53%. Now, I know that sounds terrible, but the authors also showed that all 3 arms had a 90+% reduction in AF burden. Now, the present sub-study, published in JAMA Open, was to evaluate the association of baseline AFib episode duration with post-ablation outcomes. So before ablation, patients were classified by their longest AF episode. The primary outcome of the sub-study was time to first recurrence or asymptomatic AFib or AF burden. About 3/4 of the patients in CIRCA-DOSE had AFib that lasted less than 1 day. 7% had AF lasting 1 to 2 days, 12% had AF lasting 2 to 7 days, and 5% had AF more than 7 days. The authors used the less than 24-hour group as the comparator, and they found that documented recurrences of any atrial tachyarrhythmia after ablation was significantly lower in patients with baseline AF episode durations of less than 1 day. The results looking at 24 hours versus 1 to 2 days, the hazard ratio was 0.41. If you compared 24 hours versus 2 to 7 days, the hazard ratio is 0.25. And 24 hours versus greater than 7 days, the hazard ratio was 0.23. Patients with pre-ablation AF episodes that were limited to less than 24 hours had a significantly lower median post-ablation AF burden. Now, the main conclusion was that current guidelines that classify AFib may not reflect clinical outcomes. That is because paroxysmal AFib has been defined as AF that lasted from 2 minutes to 7 days. Now, these findings add to the accumulating knowledge that patients with AFib lasting longer than 24 hours may be a different entity. Recall that first, one, cardioversion is more successful when AFib is less than 24 hours. And secondly, stroke risk seems to increase substantially when AFib lasts longer than 1 day. So the authors propose that any AFib lasting longer than 24 hours might be considered persistent AFib. And the two humbling caveats I would add to this data, and I think it's great data and a beautiful study, are that it's possible that the reason patients with short duration AFib did much better post-ablation is natural history variation. Recall that the Circa-Dose trial did not have a placebo control or sham arm. Now that's not a major criticism because no AF ablation trial has had one. But the reason this is important is that when you're looking at short follow-up of just a year, patients with short duration AFib may be more apt to have spontaneous remission of AFib. Now, I know that this may sound crazy, but I will leave you two references in the show notes on the heart.org Medscape Cardiology. The first is from Steinberg et al. In Circuit AE in 2018. They studied patients with AFib from pacemakers, and they found that, quote, of patients with a first episode of AFib that lasted 30 seconds to 2 minutes, 35% were free from subsequent episodes greater than 2 minutes at 180 days. The median AFib burden in this study was significantly less for patients with first episodes between 30 seconds and 4 hours versus those with greater than 4 hours. Now, secondly, there's a Danish study. This was published in JACC in 2019. The first author is Didriksen. These authors observed that AFib episodes recorded on an implantable loop recorder were present in 2.7%. But progression to 24-hour episodes was seen in only 16%, whereas 22%, 1 in 5, had no AFib episodes in the last 6 months of monitoring or longer. And when I had AFib a few years ago, I had short episodes of AFib for about 3 months. Then slowly and surely they went away. Had I had an ablation, I would have falsely assigned causality to the ablation. So my 4 take-home messages from this data are, we ought to have sham-controlled AF ablation trials. We ought to also be mindful of the natural history of AFib, especially when it's short-duration AFib. And we must keep reminding ourselves that the freedom from AFib results in 2020, with all of our high-tech gear, is not that much different from what Hasegawa reported in 1998. The inability to eliminate AFib with a catheter is a reminder that in many cases the atrial fib is the symptom, not disease. In many cases, the real target is upstream from the atria. A quick note in conclusion on a nice trial presented at the virtual European Heart Rhythm Association regarding pacemaker implant techniques. This was a nifty randomized controlled trial comparing self-taught ultrasound-guided axillary access for pacemakers versus cephalic vein dissection. Now, I learned pacemakers when surgeons still did the majority of them, and surgeons taught me. I know that statement ages me, but I learned the cephalic approach. But the problem with the cephalic approach is that sometimes that vein is atretic or absent, and DeBakey himself could not use it. And in these cases, you have to stick. And for years, I stuck the lateral aspect of the subclavian vein, but that raises the possibility of pneumothorax and lead crush over time. Many of my colleagues use ultrasound to visualize the axillary vein and puncture first before making an incision. And I've recently learned this technique, and I find it amazingly elegant. And Brazilian authors from Porto Alegre studied the two techniques. About 44 patients in each arm. Their primary outcome was success, and the secondary outcome, access time and procedure time and complications. And the axillary approach was better, 98% success versus 55% in cephalic. The axillary approach was also faster and associated with shorter procedure times. Now, this is a small trial. We should have bigger ones, but I like the axillary approach. It's fast and elegant. I love what handheld ultrasound is doing to transform medical practice. That said, it's good to know both techniques. There are times when a cephalic vein can save you. Super skinny patients and obese patients, for instance, it may be difficult to image the axillary vein. The cephalic approach is also nice because there is no risk of pneumothorax, and once you tie off the vein after placing the lead, there is very little risk of back bleeding. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please consider taking the time to tell a friend, writing us a review, or rating the podcast. It helps others find it. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.